One. Please start, sir.
So, good evening, and I welcome you all for the Bayer Eyesight meeting on behalf of Bayer. I am Himanshu from the Bayer Medical team. So, today we'll be having two talks. The first speaker will be Dr. Kawaljeet Kaur, who will be speaking on evolving role of aflibercept in PCV. So, just to give a little bit of introduction about Dr. Kawaljeet Manan ma'am. She is a highly accomplished vitreoretinal surgeon and uveitis specialist with over 25 years of experience in the diagnosis and surgical management of different complex retinal disorders. She is a postgraduate from PGI Chandigarh and a fellow in vitreoretina. She currently serves as a senior consultant in the vitreoretina uveitis department at Thind Eye Hospital, Jalandhar. She has over 50 plus national and international publications. So, the second speaker for today will be Dr. Jivitesh Singh, and he's a skilled ophthalmologist and eye surgeon based in Ludhiana, Punjab. He serves as the director and vitreoretina consultant at Iconic Eye Care Center, and he is a alumnus of the prestigious Arvind Eye Hospital as well as Narayan Netralaya, and his advanced specialization include vitreoretinal surgery, uvea, ROP, etc. He brings over 12 years of experience to management of different complex medical and surgical eye care. The moderator for the today's session will be Dr. Divya Yadav, and she is also alumnus of the prestigious Sankara Nethralaya as well as Arvind Eye Hospital, Pondicherry. Currently, she is working as a consultant at Dr. Om Prakash Eye Institute, Amritsar, and she also brings 10 plus years of experience in treating different type of retinal disorders to the table. Now, with this, I would like to hand over the session to Dr. Divya. Ma'am, over to you.
Very good evening, everyone. So, let me introduce the panelists for the session. Dr. David and Dr. Mehak has joined, right? Dr. Shivani is yet to join, right?
Yes, ma'am. It seems that Dr. Shivani is not joined yet.
So let me introduce the panelists here. Dr. David Agarwal, he is a VR consultant practicing at Agarwal Eye Institute, Patiala. He got trained and subsequently served as consultant at prestigious LVPI. He has an extensive expertise in both medical and surgical retina, with a special interest in diagnosis and management of complex retinal and vitreous disorders. Our second panelist is Dr. Mehak Jasuja, who's currently working in the field of medical retina at Dr. Rajbi Sohan Singh Eye Hospital. Did post graduation from GSS Medical College, Mysore, and has more than 10 years of experience in ophthalmology. So, I would now like to invite our first speaker for the session, Dr. Kawaljeet Kaur. She will be talking on. Oh, I just skipped the topic. Ma'am will be talking on the evolving role of aflibercept in PCV, APVRS insights, and comparison with anti-VEGF agents. Over to Dr. Kawaljeet, ma'am.
Good evening, everyone. Thank you, Mr. Kamalpreet, Dr. Divya, for giving me platform to present here. I shall be sharing my screen. Am I audible?
Yes, ma'am.
Yes, ma'am, you're audible.
Okay. Thank you. I shall be discussing the evolving role of aflibercept in polypoidal choroidal vasculopathy, the APBRS insights and comparisons with anti-VEGF agents. The aflibercept monotherapy achieves clinically meaningful visual outcomes in patients with subtypes of neovascular AMD like PCV. These are the disclaimers. When we diagnose the PCV, the OCT and other multimodal imaging, they help us. On the OCT, the spectral domain or the source OCT criteria, the PCV would be having sub-RP ring light lesions And on NFAS OCT, there will be complex of RP elevation and sharply peaked.
Ma'am, your voice is breaking. Is it for me or everyone?
Yes,
Yeah,
ma'am. The
it's
voice is
not
little
very clear.
feeble.
When we diagnose the PCV, now it's okay. Mr. Kamalpreet, now the voice is okay.
Yeah, ma'am, now it's loud as compared to earlier. It's now
It's breaking or like Dr.
no,
Agarwal was saying.
now it's smooth, ma'am. Earlier it was quite low and breaking as well. Now
Now it's smooth.
it's okay.
Okay. When we diagnose the PCV, the spectral domain and the sweat source OCT, the major criteria would be sub-RP ring-like lesions, and on NFAS OCT, there will be complex of RP elevation and sharply peaked PED. When these things are present, then we start the patient on anti-VEGF monotherapy, or we do the combination of anti-VEGF and PDT, that is photodynamic therapy. And then we monitor the response with the OCT or ICGA. If the patient has complete regression or stabilization of the subretinal fluid, then we gradually put the patient on a treat and extend regime. But if there is a persistence or recurrence of the disease activity, then we shorten the intervals of treat and extend regime. Normally it is 2 weeks or 4 weeks, then we have to shorten the interval, or we can combine with PDT, or we can just switch to another anti-VEGF agent. And when the patient is having a large submacular hemorrhage, then the pneumatic displacement with or without vitrectomy and TPA can be done. And if there is active extrafoveal lesion, then we can do laser therapy with anti-VEGF agents. The APVRS guidelines say the monotherapy with anti-VEGF treatment is effective in many cases of PCV and can be used as monotherapy. And till date, there is no data exploring whether faricimab or Broly monotherapy are non-inferior to combination therapy PCV patients. So we have 4 molecules: aflibercept, Broly, ranibizumab, and faricimab. And the KD value is actually inversely proportional to binding
Uh,
affinity.
Ma'am, sorry to interrupt you. Just that I think again your voice is, initially the sentences are louder and then it is becoming, so
It's
if you,
not coming smoothly.
no, ma'am, it's other people. Can you hear, ma'am, loudly?
No, ma'am. Initially the pace was good. Now again it has.
I don't know, there must be some internet connection. Now it's coming smoothly.
Uh,
Mr. Kamalpreet, how is the voice now?
no, ma'am.
So one thing we can do is if ma'am can rejoin. What do you suggest, Dr. Himanshu?
Yes, ma'am. Maybe.
Yeah. Ma'am, if you can please leave and
Okay,
join again, that may
I'll
solve
send
the
it.
issue, it seems.
Okay, okay.
Kamalpreet,
Yes, sir.
Yes.
I think our microphone is somehow blocked, maybe by our hand or by
Maybe.
something.
Could be, sir.
Because in between the voice is clear and intermittently it's going off.
Yeah, that may be the reason, sir.
Mhm.
So once she rejoins, sir, we will check and let her know if the problem persists.
Mhm.
Hello everyone. Now my voice is clear.
Hello.
Hello,
Yes,
Mr. Kapoor, my voice is clear now.
It is clearer than before, ma'am.
Then
But still, it's okay.
Okay.
yes.
Should I start from the beginning or what you suggest?
You can continue, ma'am, from
Ma'am,
your.
from where you have left, ma'am, that is fine.
Okay. 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 We have 4 molecules currently available.
आप मेरे को बोल रहे थे
Dr. Vidlak, can you?
According to APBRS guidelines 2025, monotherapy with anti-VEGF treatment is effective in many cases of PCV and can be used initially as monotherapy. Now my voice is coming smoothly. Hello.
Yes, ma'am, it's better, but still a little bit low, ma'am. I don't know. Last time it was very good, at a very good tone and pace. This time
Okay.
somehow.
Okay, I'll pitch.
In the previous slide, it was better, ma'am.
Okay, today there is no data exploring whether faricimab or broly monotherapy are non-inferior to combination therapy in patients with PCV. Now the pitch is okay?
Much better, ma'am. Much better.
Okay. We have 4 molecules available: aflibercept, broly, ranibizumab, and faricimab. KD value is inversely proportional to the binding affinity. So in aflibercept, it has very low KD value, and as compared to other 3 molecules, and it has high estimated human half-life. And it acts on 4 targets. It is has multi-targeted role rather than a single target on with the 3 molecules. In 2016, pivotal aflibercept trials demonstrated that PCV can be treated similar to neovascular AMD, and mean change in best corrected visual acuity at week 96 in patients with both PCV and non-PCV. They achieved similar vision gains with aflibercept monotherapy, and PDT observed rescue therapy for the suitable patients. Nowadays, we don't have PDT, so we are following the aflibercept monotherapy only. PLANET study was a prospective sham control study assessing the efficacy of aflibercept monotherapy compared to aflibercept PDT for the treatment of patients with PCV. Patients enrolled were 18. It was a prospective multi-center double-masked sham control trial, randomized trials across 62 centers. In all these patients, the 3 initially monthly doses of aflibercept milligram were given to all the patients, and then the randomization was done. In group 1, after the 12th week, the Eylea was given at 8 weeks as monotherapy or rescue treatment with the sham PDT, and in the other group, the aflibercept was given at the interval of 8 weeks or rescue treatment with active PDT. And the primary endpoint was at 1 year. After 1 year, aflibercept was given in a treat and extend regime, and in the first group, and in the second group, it was given as a treat and extend regime along with active PDT. So the vision gains were maintained using monotherapy with optional treat and extend dosing in the year 2. And in first year, the injections required were 8.1, which reduced to 4.6. The patients required in the second year. So the patients with extended intervals in year 2 maintained vision gains with reduced treatment burden. The number of injections they reduced in the second year. In the first year, the aflibercept monotherapy and with the rescue PDT, the vision gain was plus 11 letter gain in both the groups, and the mean number of injections they required, they were 4.1 in the monotherapy, and with rescue PDT it was 4.4. And in the second year, when the aflibercept was given in treat and extend manner, in the monotherapy group, there was 10-letter gain and the mean number of injections reduced to 3.9. With rescue PDT, the mean gain of letters were plus 11 and the number of injections required, they were 4.2 in second year. In Altair study, the vision gains were maintained with the aflibercept 2 milligram treat and extend manner with or without PCV patients. So whether the patient was having PCV or neovascular AMD, in first year the number of injections were approximately 7, and in year 2 it was approximately 3.5, and in non-PCV in year 1 it was approximately 7, and year 2 the number of injections required were approximately around 3.5 to 4. And a similar proportion of patients with or without PCV were extended to intervals of 12 weeks by week 96, that is year 2, with aflibercept 2 milligram treat and extend manner. And in the PCV group, the vision was maintained when the injection was given at 12 weeks interval, and similar was seen in the non-PCV group. Maruko et al. Reported similar outcomes with aflibercept 2 milligram treat and extend through 2 years, regardless of the neovascular AMD subtype, whether PCV or non-PCV. So, in the mean change in the best corrected visual acuity, it remained the same through years 1 and year 2. And in PCV groups, the mean number of injections year 1 was 7, and in year 2 it was 5. And in neovascular AMD, in year 1, number of injections were 7.8 and it reduced to 6.5. And the letter gain was plus 6 letter gain in PCV group and 8 letter gain approximately in neovascular. So real world patients with PCV can achieve vision gains comparable to those in the randomized controlled trials. The Hosokawa et al. In 2017 and Morrison et al. In 2018, they showed that there was 8-letter gain in year 1 and approximately plus 9 letter gain in year 2. And with aflibercept, there is complete polyp regression. It has been observed across real world case series with the PCV. There is complete polyp regression with aflibercept monotherapy. Salvin study was a single-arm, open-label treat and extend style, whereas the Planet study was a fully randomized and masked trial, explicitly designed to compare the aflibercept monotherapy versus combination with rescue PDT. In Salvin's study, the faricimab was used. It was multi-center, open-label single-arm study, and faricimab 6 milligram was given. 4 monthly doses were given. So one dose was more as compared to the aflibercept. And the main change in the best corrected visual acuity from baseline, it was averaged over week 40 to 48. And ICG and OCT were used to grade the polyp regression or inactivation. Whereas in Planet study, the aflibercept was given in 3 monthly loading doses. One dose was less. And then the second year, it was given in treat and extend manner. And it was combined with PDT. And outcomes included absence of polyps and absence of leaking polyps at week 52. Aflibercept versus faricimab in PCV patients after 3 loading doses, significant visual outcomes were observed with aflibercept. Hara et al. They compared it, and the best rated visual acuity significantly with the aflibercept monotherapy after 3 initial loading doses. And the number of injections required were less with aflibercept, and the polyp regression was much better seen with aflibercept as compared to faricimab. And in the Salvin study, faricimab have one dose of injection was given more as compared to aflibercept monotherapy. So, Hara et al., they concluded that the head-to-head comparison real-world study in treatment naive neovascular AMD, all patients were Japanese population, and both the molecules they were given, and they concluded that they are effective in reducing the exudation and retinal thickness. However, aflibercept was more likely to eliminate the exudative changes and improve the visual acuity after loading doses. So both treatments are effective, but aflibercept is more effective in reducing the exudation. So to conclude, aflibercept's 2 milligram efficacy and safety profile has been established across the randomized controlled trials over a decade of real-world monitoring. More than 20,000 patients they have used in more than 20 countries. More than 90 million doses they have been used. And there is more than 1 decade of randomized controlled trials and real-world and post-marketing experience, and more than 13 million patient years of experience. And aflibercept is being given in BRVO, CRVO, diabetic macular edema, myopic CNVM, and neovascular AMD in NVG in Japan only, in ROP in USA, Switzerland, and Japan. And there is a low rate of adverse events as observed with this molecule. And the rate of intraocular inflammation is 1 in 10,000 units. And the rate of EDOF reported is 0.6 in 10,000 units. And there is no immunogenic response. Okay, thank you. I hope I was clear. My voice was clear. Hello, everyone.
Hello, Bob. Thank you for the talk, Dr. Kanwaljit. We'll be having discussion at the end. So now let me invite our next speaker for the session, Dr. Jivitesh Singh. He'll be talking on critical information for clinicians to enhance patient outcomes in neovascular AMD. Over to Dr. Jivitesh.
Hi, hello everyone. This is Dr. Jivitesh Singh here. So I'll be sharing my screen. Kamalpreet, is the screen visible?
Yes, sir. Screen is visible and your voice is also loud and clear.
Okay, fine.
It's visible, sir.
So most of my slides are shared with ma'am, but still I would like to run through the slides and make a final point what ma'am was saying. So neovascular AMD, what the clinicians should know. 1 second. So these are the disclaimers. So just a very brief overview. World's population is 8.2 billion. 196 million are suffering from AMD. Symptoms, as we know, is a lot of central blurring, visual distortion, central scotoma. So symptoms same, the central vision is compromised. Stages of AMD, we know it starts as drusen's and keeps on progressing forward. So basically divided into 2 types. One is dry AMD, we know, and the one which we are discussing today, the neovascular AMD, which is the most aggressive form of AMD, which leads to rapid vision loss. So these are all the diagnostic modalities we know. One is visual acuity, Amsler grade, retina exam, fluorescein angiography, OCT, and ICG examination. So this is the first important slide. The time lost is vision lost. Unlike cataract, in neovascular AMD, if we don't treat on time, it leads to like subretinal hemorrhages, scarring. So the time which was lost, so even if you give however much treatment you give, you cannot gain the visual acuity if the treatment was given on time. So yeah, this is another important slide for the pathology. There is VEGF-A, there is placental growth factor, and whenever they bind to the VEGF receptor 1 and the VEGF receptor 2, they lead to a lot of inflammation and neovascularization, which promotes vascular leakage and leads to the pathology known as neovascular AMD. So this slide shows how the different anti-VEGF agents act on the pathology. Brolucizumab acts mostly on VEGF-A, same as ranibizumab. It acts on VEGF-A. So this leads the placental growth factor to keep on inciting more and more inflammation, and the disease is left unchecked with these molecules. So here comes the role of aflibercept. It works both on VEGF-A, VEGF-B, as well as placental growth factor. So it gives a more like a comprehensive attack on the pathology. This slide was discussed by ma'am also. Like the aflibercept has the highest affinity. It has a maximum half-life. It targets 4 molecules, as we've discussed before, as compared to every other. Only faricimab has a dual target, which comes little close to aflibercept. So this study was also discussed by ma'am, the Altair study done on Japanese patient. So they had quite a few PCV patients and other neovascular AMD patients. So the main change in BCVA from baseline in ETDRS letters and injection number at week 96, that is 2 years. With the 2-week arm, it was 7.6 and the mean total number of injections 10.4. And the 4-week treat and extend, it was the gain was 6.1 and the total injections being 10.4. So the vision gain achieved in year 1 were maintained to week 96 with fewer than 4 injections in the year 2 in both the treatment groups. So in Altair, up to 96.2% of the patients extended to Q16, that is 16 weeks, maintained this interval to week 96 with aflibercept. Aflibercept can achieve vision gains that are maintained in long term in the neovascular AMD. So the vision gains maintained, one second. Is my screen visible?
Yes, sir. We can see it.
One second, I will lost. Okay, the vision gained maintained for approximately 4 years was continued with the proactive dosing as per the study protocol. So a study from FRB registry showed that the treat and extend achieved good visual gains with the reduction in treatment burden in the 2nd year. So mean number of injections over 2 years with aflibercept was 13.6. By month 24, 24% of the eyes were being treated at an interval of 12 weeks and beyond. So this is another real-world study from Move Fields, which demonstrated that vision gains achieved with aflibercept at 2 Q8 intervals in year 1 were maintained in long term to year 4 and with continued proactive treat and extend dosing. So as mentioned, the mean number of injections in year 1 was 7.4, over 2 years was 12.3, 3 years 16.5, and over 4 years only 19.3. So by month 24, 52.8% of the eyes were being treated at interval of 12 weeks and beyond. So another study by Jaggi et al., the proactive treat and extend with aflibercept led to long-term maintenance of vision gains, even in the absence of initial loading phase. So here also it shows maximum injections in year 1, in year 2, 13.2, in over 3 years, 19.4, and over 4 years, 24.9, still maintaining a good BCVA from the baseline when the treatment was started. So the randomized controlled trials versus the real world evidence. This slide was also shared by ma'am. So I will not discuss this again. Yeah. Although not common globally, PCV is more prevalent across patient population than previously thought. That is very true. As the Altair study was done in the Japanese patient, it focused mainly on the Asian group. So PCV, okay. Yeah, Planet study. This study was basically focused to see the role of aflibercept monotherapy as compared to aflibercept plus PDT for the treatment of patients with PCV. So it total 318 patients. Everyone was given 3 monthly doses of aflibercept 2 mg, then randomized 1:1. At so week 12, aflibercept Q8 monotherapy and rescue treatment defined as aflibercept Q4 plus sham PDT. Here the PDT was not actually given. And in the other arm, the PDT was basically a rescue therapy in very active diseases. So after week 52 was the primary endpoint where they studied the change in BCVA from baseline and other safety outcomes. So this is the result. Aflibercept monotherapy resulted in vision gain of more than 10 letters from baseline at week 52. So the aflibercept monotherapy, the total gain in BCVA was 10.7, and the one with aflibercept with rescue PDT was 10.8, which is very, very similar. So this was one of the landmark studies which showed the importance of aflibercept in PCV. So the same slide. In both treatment arms, more than 80% patients showed no active polyps at week 52 or like 96 and or 96 weeks as well. Okay, complete polyp regression has been observed across multiple clinic trials and real-world cases series with aflibercept and PCV. So I think this slide was also discussed by ma'am. So this shows the ocular safety with the various anti-VEGF agents. We have seen that brolucizumab has a higher incidence of retinal vasculitis and retinal vascular occlusions. So we should avoid giving in maybe cystoid macular edema associated with central retinal vein occlusion. At least I try to avoid this. Then I think these intraocular events are least with aflibercept. One second. Okay, so aflibercept's 2 milligram efficacy and safety profile has been widely established across all randomized control trials and is supported by over a decade of real-world PV monitoring. These were two of my clinical cases. This is a male patient, approximately like 55, 60 years. So only after one injection, if you can see my cursor also.
Yes, sir, it's visible.
Okay, so here was the pathology which is defined by like a prominent sharp yellow area, and this is the neovascular AMD which we are seeing, and over time it is trying to flatten out, and the pathology itself is kind of diminishing. This is only after one injection. I had given initial injection of a biosimilar ranibizumab, but that didn't work at all. So after discussion with the patient, we gave an Eylea, and I think it is working now. Still, the patient is on follow-up. I have to follow him another month now. This is one more patient I've been following up for 2 years. Initially, this bud was very small, so I was following him up. He has initially received brolucizumab 1 year back. So now he came to me that I'm having distortion in vision. So I discussed with him and told him we can give Eylea. So that is also, so you see the fuzzy borders which are visible here. They are also settled. The central macular thickness has also decreased. So these two cases I had, which I thought I can discuss. Over to the panelists.
Thank you, Dr. Jivitesh, for the insights. The forum is now open for discussion. I would like to invite our panelists and audience for the same. Audience can ask their questions in comment box, in the chat box. So my question is for Dr. Kanwaljit. Am I audible?
Yes, yes.
Can you hear me, ma'am?
Yes,
Okay.
sir.
So since PDT is not available nowadays and we are anyway practicing monotherapy, so in what cases you prefer to do ICG in cases of PCV where you want to do focal laser to the extrafoveal polyps which are quiescent, or you do ICG in routine cases also?
We used to ICG in PCV cases and to look for.
We can't hear you, ma'am, properly. Your volume.
Okay. Now it's visible,
Yes, ma'am, you're
audible also.
yes, yes, ma'am.
Earlier we used to do ICG for the to look for the polyps, the choroidal lesions. They are more visible on ICG, and we can do localize them, and we can do PDT. But nowadays, PDT is not available. Only at Arvind Eye Hospital, Dr. George is doing. Since then, we are using aflibercept as monotherapy. Now we have actually angio-OCT also available, that is wide field, and you can also see the choroidal lesions there also. And we usually perform ICG in these cases.
So, do you feel like can we treat PCV without there are setups where we don't have ICG? So, do you feel we are lacking in anything?
Yes, sometimes we diagnose the patient as exudative AMD, and just on the FFA, where FFA is available, we just do the angiography, and we are just injecting and the patient is not responding. And there comes the role of ICG. We have to do the investigation properly, and I have treated large number of patients they were diagnosed with just neovascular AMD, and they have been given multiple injections. And when they were referred, and when we did the ICG for the localization of the disease, and then just switching the anti-VEGF, they were taking ranibizumab, and I just switched to another anti-VEGF agent, aflibercept, and there was markedly decrease in the subretinal fluid, and patients, they were very happy. So I think we are lacking in that, and the ICG has a role to play, because just you are just injecting and the patient is not responding, then that is the point where we are lacking.
Absolutely agree. My next question is for Dr. Jivitesh. So, what's your experience with aflibercept in treating recurrent PCVs which have responded very well previously, and now there is recurrence? So, do you prefer to switch to give alternate anti-VEGF, or you continue with the same?
Actually, I think I prefer aflibercept now, just because looking at its mechanism of action, as we have discussed, as it is focusing on a lot of molecules, maybe which other brolucizumab or other, especially the ranibizumab, they are missing on the placental growth factor. They're binding to the VEGFR2. So I like to sometimes, especially because of the cost factor, I might start with the lower molecule like a biosimilar of ranibizumab. But ultimately, I think when I feel it is not responding, then I continue with Eylea or the aflibercept. That is my drug of choice right now.
Definitely. Even I feel the durability of Eylea is much better than the other anti-VEGF.
Yeah. Yes,
If we want a long-term sustenance of the treatment, Eylea does much better
definitely.
job.
It has longer half-life, so you can observe for longer time also. Even sometimes the patients don't come on time for follow-ups. So a
Definitely.
lot of Indian factors are there.
Okay. And have you faced any safety concerns in nephropathy patients treating with aflibercept?
Nephropathy specifically?
Yes.
I don't remember any such cases. Some or most of the people I'm treating for neovascular AMD, they are not having uh, they would, so my experience there is like not much in that scenario.
Yes, this aflibercept, I think they are looking for
Ma'am, your voice is not very much audible. So
I just want to
it's
comment.
better now.
Ma'am, I think your microphone is blocked. Where the source of sound should come.
I don't know. I'm just very close to my laptop even then.
Now we can hear you
keep,
clearly.
ma'am, you keep your hands, I think your hands might be unknowingly blocking the
No,
microphone.
they are.
Okay. Okay. Now it is
I
audible,
just
ma'am.
Okay, I just want to comment like Dr. Divya is commenting about use of Eylea in nephropathy. Like people are using Eylea and diabetic macular edema also. Maybe you might have that concern that these patients, diabetic patients, they have nephropathy. So we have a very less experience of aflibercept in diabetic macular edema. Maybe you were concerned with this.
In diabetic macular edemas, I also prefer to give a biosimilar or maybe like Eccentrix
Steroids.
is enough, or steroids in like
Steroids, yes.
maybe the resistance cases. Steroids
Yes.
work sometimes very wonderful.
Better. Mhm.
Eylea, aflibercept I have reserved for like neovascular AMD and TCV.
Yes.
There it is my drug of choice. Matlab, I
Choice.
tell the patients to opt for it if it is economically possible for them.
Yes.
I'm saying.
My question is for panelists. Dr. Mehak is there. Dr. Mehak and Dr. David is there. Are they there with us or not? Dr. Mehak, are you there with us?
Hello. Yeah. Can you hear me?
Hello. Welcome, Dr. Mehak.
Yeah.
My question is for you. So in what cases, what is your preferred line of drug, like the drug of choice for cases of PCV, the first line of drug, because there are newer molecules which are coming up, like faricimab, and we have like good experience with Peginex. So what is the preferred drug for you in
The
PCV?
preferred drug is obviously Eylea. I haven't used brolucizumab much, and I've been using faricimab in few of the patients, but preferably I give Eylea. And if the patient is really not affording, and then maybe ranibizumab, but otherwise, yes, Eylea is the drug of choice.
Even I feel the Eylea, the onset of faricimab is little slower in PCV or CNVM cases where we want an earlier onset of action because the vision is lost with time. So I feel Eylea does a faster job and compared to faricimab, especially in neovascular AMD cases.
Yes, and the patient satisfaction is also there, so that's preferable.
The patient satisfaction as well as the doctor who's treat, they also get motivated once they see the response. So
Yeah,
I think
definitely.
it works faster compared to the newer molecule.
Yes, yes.
Anything you want to add, ma'am, Dr. Kamalji?
We have seen cost is not a big factor nowadays with the patients.
Sorry, ma'am, your voice.
I'm saying cost is not a big factor.
Big factor.
Definitely.
Nowadays, we have seen with the patients, they just want a very good treatment, and cost doesn't make much difference now.
Definitely. Any questions from the audience? Mr. Kamal, I think we have something in
So
chat.
I think, ma'am, we can check once. Dr. David, have you joined, sir? I could see your name. Good evening, Dr. David. Have you joined? Yes, ma'am. What are you saying, ma'am?
Do we have any questions from audience?
No, ma'am, we have not received any
In the
questions
chat,
in
yeah.
the
Chat box.
chat box. I have checked the chat box, and I think there are no questions from the audience.
Okay. So I want to ask one questions to our speakers. So in cases where there is submacular hemorrhage in PCV cases, so what is your drug of choice? And along with, of course, we are giving gas pneumatic displacement. So what is your drug of choice in those cases where hemorrhage has already happened? Do you prefer one molecule over other in those cases?
Molecule of choice remains the same with surgical intervention also, depending on obviously the pneumatic displacement plays a important role. But I think better to stick with Eylea only.
Okay.
So my drug
And
of choice is
I
that
would
only.
like to add, like, where cases where we are using tissue plasminogen activator,
Mhm, mhm.
we are for dissolving the clot. In those cases, I think the aflibercept molecule is not contraindicated, but it is not the preferred drug because the TPA itself cleaves the protein, aflibercept protein. So in those cases, maybe we need a higher dose of aflibercept, or maybe we can use biosimilars.
I think their team is coming up, already has a
Yes.
Eylea HD in the international market. I was discussing with Kamalpreet today when it is going to come, what will be the costing. So
And
anyways,
we
that they have to
have
tell.
experience with that also.
So, sir, just to update on you, we have received the good news today itself, and we
Okay.
have been granted to launch 8 mg by the DCGI today itself, and we'll be doing a phase 4 study, and hopefully within 4 to 5 months, the drug will be in the market. The only obstruction was that we were not getting approval from the DCGI because in the phase 3 trials of Eylea 8 mg, Indian patients were not the part of it. So they wanted us to do, some kind of study in the Indian patient just to ensure the safety of the higher concentration in the Indian population as well. So now we have agreed to doing that study, and hence on basis on that condition, we have been granted the approval. So it will take max 4 to 5 months to hit the market.
I was going through your Pulsar study also, where it was showing that we can treat and extend even beyond
So,
what
sir,
typical
again,
studies.
just to update on that, in Europe, Eylea 8 mg is the only molecule which has been granted 6 monthly regimen for AMD, PCV, and as well as DME. And whereas in US, the regimen is 5 months. Till now, the maximum duration which was allowed between the two injection was Q16 for faricimab. But now with Eylea, the Pulsar and the Photon results, they have shown that almost 25% of the patient they are extending beyond 6 months also. So based upon that data, they have recommended that it can be used 6 monthly in the patients who are extending. So it has shown a great deal of durability, and it has been almost 3 years since it has been used in US, Europe, even the Asian markets including Australia, Taiwan, Hong Kong. So it has been doing very well.
So anyways, once the product come, then you guys will tell better. So we can
Yes, sir.
start, once it is in the market, you can start the treatment directly with the Eylea HD as well, or like it is for maybe after the loading dose.
No, sir. So because in the markets which is there, it is already there. Mostly the doctors have opted to switch the patients from 2 mg to 8 mg entirely. Almost 80 to 85% of the patient has already been shifted because there the cost is not the concern. And their
Mhm.
point of view is that if a drug which is promising to be providing a better durability, why we should start with a therapy
8
which
mg
is
loading doses, monthly loading doses also
3 loading doses, ma'am.
of 8
Both
mg.
in
With 8 mg
Yes,
only.
ma'am. Yes, 8 mg.
Okay.
but the patients who were already on Eylea 2 mg, they will not require those loading doses. But from other therapy, if you're switching, because obviously the molecule gets changed, the mode of action gets changed, so in that cases it is required to start with the 3 loading doses.
I think a lot of biosimilars also coming in the market right now to compete with you guys. So I think your
2
Eylea
mg.
XP can do your game up. I think they're all coming in 2 mg. I have not tried
Yes,
anything.
sir.
I've just heard one name. I have not tried at my center because there were some flying reports of some intraocular inflammation. So I was not
Yes.
sure about that.
So Anira, it has been used in Delhi, and with 2 or 3 batches, there were reports of 7 to 8 adverse events, and few were very severe also. I think VRSI floated a cautionary notice also to the doctors. So after that, the adoption of Anira has stopped a bit at least at the prominent centers here in Delhi.
The time will tell their fate, I think, about 8 mg also.
Yes.
How you cost it, I think, is going to make a difference.
So,
How
sir,
much is there going to be the difference actually?
cost is not out yet, but it will come with the patient support program, that's for sure, which was earlier there with Eylea 2 mg. So it will be launched from the beginning itself, the patient support program. Cost is yet to be decided. I'm not aware of
I
that right
think
now.
the systemic, the higher dose, the systemic profile also has to be studied of the patients because
True.
Yes, ma'am. So there are 2 or 3 questions which in the international markets are faced continuously. First, the volume of the this injection will be increased. So for 2 mg and other drugs, it is 50 microns, 50 microliters. For this, it will be 70 microliters. And so there have been a bit of concerns regarding the increase in IOP, transient increase in IOP and all. But they have conducted thorough studies, trials, as well as real world evidence studies where they have evaluated whether there is an impact on IOP, not reported as of yet. Again, you rightly said that since the drug is high in concentration, there are chances that there is a higher level of systemic exposure. But so far so good, ma'am. We have not received any kind of such adverse event reports. Fingers crossed.
You can give some disclaimers while your people representatives meet where to be cautious. So anyways, once it is out, then it's the point of discussing.
Interval would be the same as with 2 mg, 4 weeks interval.
Ma'am, there will be 3 loading doses, and then it can be increased to Q12, Q16, or even Q20 and 24, depending upon the response of the patients.
The loading doses would be at 4 weeks interval only.
Yes, ma'am. Yes, ma'am. 3 monthly loading doses. So for 2 mg in AMD, as per protocol it was 3 loading doses. For DME it was 5, but with 8 mg, since the concentration has been increased in DME, also the prescribed loading doses will be 3. Obviously, if the patient and doctor both are on the same page.
so looking forward to that.
Yes, ma'am.
8 mg. I think either or we can customize the treatment with loading doses of 2 mg and then maybe depending upon patient's profile and the
It can
safety
be.
concerns.
It can be done, ma'am. So basically, what is recommended in the countries where dual strategy is there, that means both the drugs are coexisting. So there they are not shifting the patients who are maintaining or Q12 or beyond Q10. But in other markets, mostly they have switched, because what they believe is the patient who is maintaining at Q12 with 2 mg has the potential to increase till Q20 or Q24, because those are considered to be good responding patients. And the patients who are not maintaining at Q12 or Q16, and those who are maintaining at Q4 or Q8, those has the potential to go to Q12. So that's their logic. So again, it will depend upon the how the treating physician takes it.
It was a great talk on your upcoming product. and highlighting its
Thank you, sir.
previous uses.
So having said that, Eylea is now also at the top of the game, especially in cases of neovascular AMD.
True.
So preferred drug of choice for these cases.
So I think if there are no more questions, maybe then the time is also up. So maybe we can wrap it up. So I would like to thank both the speakers. Dr. Ma'am has to face a lot of issues today with her mic, but
don't
she's
know.
still sustained and she still sustained and persisted with us. So thank you, ma'am. And thank you, Jivitesh sir, for a wonderful talk and both the cases. And as always, Dr. Divya ma'am, I've listened to you a lot of times in different conferences, and thank you for the wonderful moderation and the audience as well.
Thank you so much.
Thank you. Thank you so
Thank
much.
you. Thank you.
Okay, have a good night, everyone.
Good night. Good night.
Good night, doctor.
Yeah.
Thank you so much for joining.
Thank
Tech team, we can stop now.